Now we shall be discussing some important points regarding your vascular surgery, followed by a few important points from thoracic surgery before moving into abdomen and the urology. So in vascular surgery, mesenteric ischemia. Now, acute mesenteric ischemia is basically thrombotic or embolic. Now, the embolic occlusion is because of the embolus that mainly travels because of any cardiac issue. Now, the embolic occlusion is going to lead to your severe sudden abdominal pain, vomiting, and diarrhea. Now, the investigation of choice in this scenario is going to be your CECT whole abdomen. Now, what would you do? The treatment would be your resection of the dead bowel, embolectomy of SMA, and if needed, they might be required of a secondary look laparotomy. Now, in case of a non-occlusive acute mesenteric ischemia, you have your excessive sympathetic activity during your systemic hypotension, as a result of which there is your vasospasm. Now, the treatment includes your papaverine injection and your prostaglandin E1. Now, in case of your chronic mesenteric ischemia, you have your asymptomatic occlusion at one or more vessels. Now, it is usually referred to as your abdominal angina. Now, the features of this include your cetophobia, postprandial abdominal pain, melanoma, and diarrhea. Now, the treatment includes your surgical and your endovascular treatment. So, this were your few important points regarding your acute mesenteric ischemia. So, you usually get a clinical based scenario question where you are asked regarding what is the diagnosis. Right. Now coming down to the next important topic, a small topic, which is your aneurysm. Now this is the dilation of your localized segment of the arterial system that is usually more than 50% increase in the diameter. Now the classification of aneurysms would be on the basis of wall. It is true or false. Now the true aneurysms are those where you have three layers, that is your intima, media, adventitia, whereas false are those where you have your single layer of fibrous tissue. Now, morphology, you have your fusiform and saccular. And on the basis of etiology, you have your erythematous, mycotic, collagen disease, and your traumatic. Now, the most common large vessel type of aneurysm is your abdominal aortic aneurysm. And the aneurysm measuring twice the size of the corresponding normal vessel have the chance of becoming symptomatic. So, basically, it is the size measuring twice the normal size, right? And then when would you require an operation in asymptomatic? When you have size more than 5.5 centimeter. So that was an indication for surgery, and the morphology is best assessed by your CT scan. And open surgical repair is less contraindicated. That is, reserving EVA is high risk patients and your hostile abdomen. So open surgical repair is usually done unless it is contraindicated, until reserving your EVAR for your high risk patient and your hostile abdomen. Now, regarding your management of your ruptured abdominal aortic aneurysm, it would be your early diagnosis, immediate resuscitation, maintaining systolic blood pressure, but make sure that you do not make the blood pressure more than 100 mm of Hg, urinary catheter, cross-match blood, and rapid transfer to your operating room. Now, EVA should be considered as a suitable for your ruptured aortic aneurysm as the first line, right? Now, there is another table which has been added in your recent Bailey and Love edition, which is the classification of your endo leaks. So, your type 1 is your persistent filling of your aneurysmal sac owing to an infective seal at the proximal or distal end of the stent graft. Proximal would be 1A and distal would be 1B. Then you have your type 2, which is a persistent filling of the aneurysm sac owing to the retrograde flow of blood from the aortic collateral. Then you have your type 3, which is a persistent filling of the aneurysmal sac owing to the structural failure of the stent graft. Now it is as a result of component disconnection, that is 3A, and as a result of stent fabric tear, it is 3B. Then you have your type 4, which is a persistent filling of the aneurysm sac owing to your stent graft fibric porosity. and you have your type 5, which is your endotension. Now over here you have your persistent filling of aneurysm sac without any evidence of type 1 to 4 of endo leak. So this is a new addition in your Bayesian law, so be prepared to be getting a question from the classification of the endo leak. Now again, a very small topic yet a very high yielding topic is your aortic dissection. So this is a defect or flap in the intima of the aorta, as a result of which the blood tracks into the aortic tissue, splitting the medial layer and creating a false lumen. Now it is most common in your ascending aorta, which lies just distal to the left subclavian artery. Now it is much more common in male compared to females, and age is usually 50 to 70 years. Now predisposing factors for your aortic dissection include your age, hypertension, Marfan syndrome, pregnancy, giant cell connective tissue disorders like Ehlers-Danlos syndrome, giant cell arteritis, systemic lupus erythematosus, coarctation of aorta, Turner or your Noonan syndromes, and aortic cannulation site following your previous cardiac surgeries. So these are your few of the risk factors or the predisposing factors for your aortic dissection. Now the clinical features. You have your classical features as your tearing interscapular pain. Now, if this dissection descends distally down the aorta and spiral to involve the renal arteries, then what will you find? You will find your renal pain and renal failure. If it is mesenteric arteries, you will find features of abdominal pain and bowel angina. If spinal arteries, you might find patient presenting to you with paraplegia, and iliac arteries would lead to leg pain, pallor, or acute limb ischemia. Now, they also may track proximally to involve the head and neck vessels, coronary vessels, and your aortic root. If they involve the coronary vessels, they may lead to myocardial infarction. Now regarding your classification, remember you need to remember your two classification, which are your Stanford and your DeBakey classification, right? So Stanford classification of aortic dissections are whether it is involving the ascending aorta or not. So now when we are talking about Stanford, it is A or B. So if you see over here B, now if in type B ascending aorta is not involved, in type A ascending aorta is involved. Now in case of your Stanford in case of your DeBakey classification, you have your type 1. Now type 1 is your ascending plus descending aorta, type 2 is only your ascending, and type 3 is your descending. So DeBakey type 1 is your ascending plus descending, type 2 is your only ascending, and type 3 is your descending, right? And now this is actually DeBakey's type B of Stanford, and this is type A of Stanford. Now another very important feature seen in X-ray is your widened mediastinum. So this is going to be one of your diagnostic findings, which if you find is going to hint your diagnosis towards your aortic dissection. Now diagnosis is confirmed by the CT scan, and the treatment would include your BP control, and type A would involve your surgery intervention, and type B would usually be your conservative treatment. Now coming down to the vascular part. Now first in arterial. Now you need to understand this important concept of intermittent claudication. You must have got a lot of patients in your outdoors or in your ward clinics of your peripheral arterial disease. So let's understand what an intermittent claudication is. It is usually the result of your anaerobic muscle metabolism. So it is a cramp-like pain, that is first point, brought on by walking. It is usually not present on taking the first step. Now, if it was first step, it was actually an osteoarthritis, and then it is relieved by taking rest for less than 5 minutes. Now, in case of if it was a spinal stenosis, then your rest requirement would have actually been more than 5 minutes. So, these are your few important points of intermittent claudication that you guys need to remember. Now, this muscle groups affected by claudication are usually one level below the level of claudication, and the most common vessel affected is your superficial femoral artery, causing a posterior calf pain. Now regarding your rest pain, so this is a continuous dull type of pain which is not relieved by the usual dose of analgesics, which persists for more than 14 days, that is around 2 weeks. Now the ulceration and gangrene. The ulceration is usually a sign of severe arterial insufficiency, and you can see over here image showing the gangrene, gangrenous changes of the great toe and the toe adjoining. Now, another important concept is of your critical limb ischemia. So you have your questions being framed from your critical limb ischemia. So it is a persistently recurring rest pain requiring analgesia for more than 2 weeks, or ulceration or gangrene of foot or toes with ankle systolic blood pressure less than 50 mm of Hg and toe systolic pressure less than 30 mm of Hg. So these are your few basic concepts of your arterial disorders which I want you all to know, because what happens is that in order to like read a lot of MCQ points and MCQ books, we actually tend to skip on this basic point, and the questions are being actually picked up nowadays from this important topics. Now again, this another table is very important. Almost all exams have got questions from this table. So the clinical findings to the site of the disease. So in case of aortoiliac obstruction, there's claudication in the buttocks, thigh and calves. Femoral and distal pulses is absent in both limbs. Bruit over the aortoiliac region, and most importantly, Lerich syndrome, that is aortoiliac obstruction with your impotence. Now, if it was an iliac obstruction, you would be finding a unilateral claudication in the thigh and sometimes the buttock, bruit over the region, unilateral absence of your femoral and distal pulses. Now, if femoral popliteal obstruction, you have a unilateral obstruction in the claudication in the calf region. Femoral pulse is palpable with your absent unilateral distal pulse. Now, in case of distal obstruction, you have your ankle pulses absent, whereas femoral and popliteal pulses will be present, and there will be claudication in the calf and foot. So this is again a very 5-star important table where you are just basics would help you to solve most of the questions, right? Now another examiner favorite is your Berger disease, which is your vasculitis involving your medium and small vessels. It may occur both in your upper limb and the lower limb. It usually involves arteries, veins and nerve. Now, there's a criteria to diagnose your Berger disease, which is your Shinoya criteria. Now, the Shinoya criteria is the onset before the age of 50 years. Smoking must be present. Infrapopliteal artery occlusion, unilateral involvement, and absence of atherosclerotic factor other than smoking. So, these were your important points with respect to your arterial disease. Yes. You might be thinking that this question, that question regarding your Rutherford classification. Yes, Rutherford classification is also important. I have not included because the tendencies, it's not that it cannot be asked. It can definitely be asked in your exam. So please make sure that you read that too before your exam. But then for this class coverage, I have just tried to add some basic and the most commonly asked questions. And for this Rutherford classification, what I'll do is I'll try to make a video and upload in the GAMEPG YouTube channel, so where you can check on it. So if you find any topics that you see that is important and has been missed, I would again repeat, guys, please feel free to drop a message or an email or in our comment section. We'll definitely come up with the part for it. Now, in the venous disorders, what I would want you all to remember is the CEP classification. Now, CEP classification, you have to remember the clinical. So before going to the clinical, let's take a look at the etiological, anatomical and pathophysiological. Etiological is congenital, primary, secondary, not specified. Now, anatomical is your superficial vein, AS, AP is the perforating vein, AD is your deep vein, and AN is your not specified. Pathological is PR reflux, obstruction, and PN not specified. Now, clinical. So you have some direct questions, or you have a clinical based scenarios where they have given a particular description and they would want you to know what is the C classification. So C0 is your no visible signs of venous disease. C1 is your spider veins or telangiectasia or your reticular vein. So varicose vein is actually C2. C3 is varicose vein with edema. Now C4A is pigmentation and eczema. C4B is your lipodermatosclerosis or atrophy blanchi. 4C is your coronophlebacteria, which is a malleolar flare, a fan-shaped pattern of telangiectasia on the ankle of foot. C5 is your healed venous ulcer, and C6 is your active venous ulcer. Right, so this is again a 5-star important topic. The last session had a question again from the CEP classification. Even the prior session of Fmge exam had a session on this. So please make sure that you revise your CEP classification. Now again, these are some of your image based. So if you can see in this particular image which I have ticked right now, so it is your telangiectasia, where you have your thread veins or the spider veins. So these are tiny intradermal venules which are measuring around less than 1 mm. Now you see over here the topmost over here, so you can see over here the lipodermatosclerosis changes. What are lipodermatosclerosis? These are your chronic inflammation and the fibrosis of the skin and the subcutaneous tissue, right? Whereas your atrophy blanchi is your localized area of the trophic white skin. Then you have your this image showing your pigmentation. This image is showing your painless groin swelling, which is your Saphina varix. And then you have your varicose, which is more than 3 mm in size. Right. So in varicose vein, you need to remember this particular points with respect to your CEP classification. Right. Now, regarding your investigations, you have your duplex ultrasound scanning, which is your reflux, obstruction, thrombosis, pelvic source of infection, and suitability of the incompetent superficial vein for differential treatment. Now, regarding your management, so if you have signs and symptoms of chronic venous insufficiency, you have your conservative managed compression. Now you have a satisfactory response to continue the treatment. If not, then you go for a duplex scan. Now, if it is a muscle pump dysfunction, you need to plan for exercise program. A non-acute obstruction, you might require a venography and a venous stenting. In case of reflux, if it is a perforator, you would require a subfascial endoscopic perforator surgery. In case of deep veins, you would require a valve reconstruction. And in case of superficial, you would require a venous stripping and a venous ablation. Now the question comes, the gold standard treatment for the varicose vein in the current generation is your endovenous laser treatment, right? So endothermal ablation is your gold standard. It is safer, efficient, super quality of life, cost effective, and it can be done in local anesthesia. You use laser and radio frequency. So in case of EVLA, you can ablate any vein. It is not used for any tortuous vein. Now it can treat, EVLA can treat, that is laser can treat your perforators, whereas radio frequency cannot. It is inexpensive, whereas radio frequency is expensive. It can deliver target form sclerotherapy, whereas radio frequency is automated and learning curve is reduced. Now, another important point with respect to your varicose vein is your tumescent anesthesia, which compresses vein into your onto the treatment device, and it hydrodissects the tissue such as the nerve away from the zone of injuries, and it acts as a heat sink, mopping excess of thermal injury. So this were your few points with respect to your arterial and the venous disorder. Now, apart from this, you have your venous ulcer. Now, what I want you all to remember in your venous ulcer is regarding your most common accepted theory for venous ulcer, and it is your ambulatory hypertension. Right, now DVT must have been covered in your medicine topics. Now what I would all you remember is regarding your well score. So in your well score, they might ask you regarding the components. So there are two beautiful tables regarding your well score. Make sure that you revise them. If not, I'm not covered over here, but what I'll be doing is that I'll be making sure that I'm going to cover this in your Instagram of channel of your GAMEPG app, or in the YouTube channel in the form of shorts. So in case if you're not reading, make sure that you follow our GAMEPG YouTube app channel or the Instagram in order to get the access to this table and charts, which I have not included over here, but I shall be including them in form of either reels or as a post just before the exam, because these tables have this tendency to be getting forgotten. So just revising before the day of exam is actually going to help you, right? So now coming down to the thoracic and the cardiac part. Now there are not a lot of questions which are being asked because they are actually an overlap between your respiratory system, which are usually covered. But one specific question which is your surgeon's favorite to be asked in exam is regarding thymoma. So it is the most common mediastinal tumor. It is related to myasthenia gravis. What is the only reliable indicator of malignancy in thymoma is the capsular invasion. Thymomectomy is usually done for more than 5 centimeter. If small, then you can actually go for a video assisted thoracoscopic surgery. Now this is the one of the most important question asked, that is your Masauka classification is used for your thymoma, right? Now in case now before that, these are your some common tumors: anterior mediastinum, thymoma, lymphoma, germ cell tumor, medial cystoma, lymphoma, mesenchymal tumor. Superior mediastinum includes a lymphoma, thyroid and parathyroid. Posterior mediastinum includes a neurogenic tumor, cystic lesion, and mesenchymal tumor. Now, apart from this, in your cardiac surgeries, you need to know the fetal circulation, which has been covered in your pediatric surgery, and your valve defects and the tetralogy of Fallot, and all these points have been covered in your pediatric section, I believe. If not, just let me know. What I'll do is I'll post a video in a separate form. What I want you all to know is regarding your bypass surgery, right? In your bypass surgery, now the most common question that have been asked is regarding your venous graft. Now in your venous graft, you guys, you need to remember it is your saphenous vein that we take, okay? And in case of arterial graft, right now the current status is regarding your left internal mammary artery. So these are your most common venous graft and the most common arterial graft that are used. So this is with all that I wanted to discuss regarding your cardiothoracic and your vascular surgery. So please do not miss on this particular points. Now we move down to the next section, which is your abdomen, right? Now in abdomen itself is a huge section itself, right? So you have books completely on one particular topic. So what I have done over here is, like, from each section I have taken the most high yielding topics to be discussed over here. And again, as I have told you, if you want any other specific focus on topic, you may just let me know. But over here we'll be just discussing a few important points in order to cover the entire abdomen, making sure that we touch them, right? So we begin our discussion with hernia. So first, regarding hernia, the anticipated question or an expected question is regarding the EHS classification, which is the European Hernia Society classification. So if it is primary, you say it to be P, recurrent it to be R, lateral you say it to be L, medial M, femoral F, and defect size in finger breadth in the value of 1.5 centimeter. Now with inguinal hernia, there are questions which are actually framed from the anatomy of the inguinal hernia. So for this anatomy of inguinal hernia, you can actually find the question in the GAMEPGAPP YouTube app channel, or you can even find the video in my YouTube channel where I've actually explained the anatomy part also, which is going to help you to solve the questions from anatomy in case if you have not revised in your anatomy section. Now, operations for inguinal hernia. Now, you might be asking, what is the purpose of this question? Now, if you remember, a while back I was teaching incision. So yes, they just ask you directly questions based on incision, which is the type of operation done, right? So open suture repair is Bessini, shoulders, Desarda, Malunident. Open flat mesh repair is Lichtenstein. Then open complex mesh repair, not recommended nowadays, is mesh plugs and hernia system. And then you have your open preperitoneal repair, which is just Stopa repair, and laparoscopic repair or robotic, that is TEP and TAP. Now with TEP and TAP coming, you need to remember two important triangles. Now these are your examiner favorite again, which is the triangle of doom and triangle of pain. Now triangle of doom, it is medially by vas difference, laterally by vessels of spermatic cord, and inferiorly by your peritoneal reflection. Now the contents include your external iliac vessels, femoral nerve, and genital branch of femoral nerve. In case of triangle of pain, it is bounded medially by the gonadal vessels, laterally by the peritoneum, and superiorly by the iliopubic tract. So the contents of this include your lateral femoral cutaneous nerve, femoral branch of genitofemoral nerve, and femoral nerve. So this is very important with respect to your hernia. You need to know the anatomy, you need to know the surgeries, and you need to know these two important triangles. Right, now let's take a step ahead now regarding a femoral hernia. Again, the anatomy part, the femoral canal. So it is laterally by your femoral vein, anteriorly by your inguinal ligament, posteriorly by your iliopectoneal ligament, and medially by your lacunar ligament. Right, so these are your boundaries of your femoral canal, and femoral canal is exploited by your femoral hernia. Now, it is more common in women compared to males because female pelvis has different shape which increase the size of your femoral canal, and it is obviously less common than the inguinal hernias. Now, the question that can also be framed from femoral hernias regarding the surgery. So again, a group of 3. So these are your 3 surgeries which are required for femoral hernia repair. Now, please remember, best for emergency repair is your McAvity repair. So this is your best for emergency repair. So these 3 important incisions surgery names you need to remember, which is Lockwood, Lawson, and McAvity. Now regarding your esophagus. Now in esophagus, I would want you all to remember this particular topic for sure, Barrett's esophagus, again being repeated over and over, and there has been an addition of a recent new table, so we'll take a look at that too. So Barrett's esophagus, it is a known complication of GORD. Now it is the proximal migration of the columnar epithelium in the lower esophagus extending 1 centimeter above the esophagogastric junction. Now, the role of goblet cells in the diagnosis has become controversial, as recently stated in your recent edition of your 20th edition of Balian Law. The last edition had told the goblet cells to be mandatory, but then there is a controversy over here. So for now, you need to follow your 20th edition of Balian Law. Now, the length of Barrett is also a risk factor for neoplasia. Now, there is a classification which is known as the Prick classification, which includes your circumferential and the maximal extent visualized on the endoscopy. Apart from that, the risk factors for Barrett esophagus includes your chronic GORD symptom for more than 5 years, advanced age of 50 years, smoking, central obesity, and male gender. So these are your risk factors for your Barrett's esophagus. Now regarding the cancer progression in Barrett's esophagus, you have your low grade, which is around 0.7%, and in case of high grade, you have your 7% progression into the cancer. So again, these values are very important. Now regarding your fetal biopsy protocol. Now fetal biopsy protocol, you have your 4 quadrant random biopsy every 2 centimeter in addition to the targeted biopsy. So please remember, 4 quadrant biopsies every 2 centimeter in addition to the target biopsy. Now, how will you treat? You will essentially treat the patient same as in you treat it for gastroesophageal reflux disease. Now, this is a particular flowchart which I would want you all to remember. So you have a flat columnar mucosa, systemic cold biopsy. Now, it's confirmed dysplasia by 2 independent pathologists. Now, if there is no dysplasia, then you repeat OGD for every 3 to 5 years. Now, if there is no dysplasia and maximum length is less than 3 centimeter, gastric metaplasia, you repeat. Now, if this length is 3 centimeter, you consider the discharge. Now, if maximal length is 3 centimeter and intestinal metaplasia. Now, that was a gastric metaplasia where you were discharging. But if it is an intestinal metaplasia, you would repeat every 3 to 5 years. Now, if the maximum length was more than 3 centimeter, in that case, you will repeat it for every 2 to 3 years, not 3 to 5 years, right? Now, if it was indefinite for dysplasia, you repeat the esophagoduodenoscopy with maximal acid suppression. If it is a definite dysplasia, you would follow a low-grade dysplasia or the high-grade dysplasia flowchart. So, if it is a low-grade dysplasia, you will do the esophagoscopy every 6 months until two consecutive evidence of your non-dysplastic Barrett's esophagus. And after that, you follow your non-dysplasia flowchart. Now, if you do and it is a high-grade dysplasia, then you take the patient for MDT discussion, therapeutic intervention, and the patient may require your endoscopic eradication therapy. So friend, this table is this chart is very important. You just need to follow the each step in order to solve the MCQs that can be framed from this, right? So now these are your some HP images which is showing your Barrett's esophagus, low grade dysplasia and your high grade dysplasia, right? So now we're coming down to the motility disorders. So in motility disorders, there has been a recent change. The previous edition had given your Chicago classification, that is third edition, but now we have the fourth edition and the updated education of your Chicago classification. Now, so let's try to understand this. So what is the step 1 of your Chicago classification? So the step 1 is to perform 10 wet swallows in primary position. Now, if there is an abnormal median IRP, right, then you check for 100% absent peristalsis or all swallows are either failed or premature. If the answer is yes, then is it 100% failed peristalsis without pan-esophageal pressurization? Then it's achalasia 1. Now, is it 100% failed peristalsis with POP in more than 20% of swallows? Then it is achalasia type 2. Is it more than 20% swallows with premature contractions and failed peristalsis may or may not be present? Then it is classified as achalasia type 3. Now, if this 100% absent peristalsis or all swallows are either failed, if the answer was no, then you go for your step 2. Wet swallows in secondary position plus MRS or your RDC. RDC is your rapid drink challenge and MRS is your multiple rapid swallow. So if there is elevated lower esophageal sphincter IRP persistent in varying position plus, just a minute. Yeah. So if it is an elevated LOS, integrated relaxation pressure persisting in varying positions plus elevated pan-esophageal pressurization and your intrabolus pressurization, then it is an abnormal TB and it is an abnormal TBO or flip. TBO is your time-barium esophagogram and flip is your functional luminal imaging plantimetry. Then it is your OGJO, esophagogastric junction outlet obstruction. Now, if coming back to this particular chart of your abnormal median IRP, if the answer was no, then you perform the second step, that is your wet swallows in secondary position and your rapid drink MRS, which is your multiple rapid swallows and your rapid drink challenge, right? So now again, if there is an elevated LOS RP in varying positions plus elevated your intrabolus pressurization or your pan-esophageal pressurization, then you again go back to this same chart of that is 100% absent peristalsis or all swallows are either failed or premature. If the answer is no, then you come down to whether there are failed peristalsis or not. If yes, then it is absent contractility. If no, more than 20% swallows with your premature contraction. The answer is yes, then it is a distal esophageal spasm. If the answer is no, more than 20% swallows with hypercontractility, then yes, it is a hypercontractile esophagus. Now, more than 70% ineffective or 50% failed swallows, then yes, it is ineffective esophageal motility. And if there is no evidence of disorder of peristalsis, consider meal-based challenge or symptom. So yes, you need to keep revising, reading this table, and because there is a potential chance of the questions being asked from this, as it has been a recent update. And based on Chicago classification, your last December session, not December, the prior session, the last June session had questions on your esophageal motility disorder. So be prepared to get a question out from this particular session. Now regarding achalasia, your most common age presentation is 30 and 60 years of age. The clinical features are dysphagia, regurgitation, heartburn, weight loss, halitosis. The classical triad is your dysphagia, weight loss, and regurgitation. Now again, a new addition in your Bailey and Love has been the clinical scoring for the achalasia, which is your ICARD score. The components include your weight loss, dysphagia, retrosternal pain, and your regurgitation. So this is your barium contrast study, which is showing your rat tail appearance of your achalasia. Now the definitive diagnosis is by your HRM. HRM is your high resolution manometry. Now the treatment is by medical therapy, calcium channel blocker, nitrates, and 5-phosphodiesterase inhibitors, botulinum toxin, pneumatic dilation, Heller's myotomy, and peroral endoscopic myotomy, which is minimum 6 cm in esophagus and a 2 cm in gastric cardia. Now esophagectomy is required for your mega esophagus. Right. So this were your important points with respect to your motility disorders. Now, regarding your hypercontractile motility disorder, so DS, it is an incoordinate, there's no incoordination, premature, rapidly propagated contraction of the esophagus. It presents with dysphagia and chest pain. It usually occurs in distal 1/3. There's hypertrophy of your circular muscle, not the longitudinal muscles, right? And you have your corkscrew appearance in your esophagogram. So you can see over here, this is your corkscrew appearance in the esophagogram, right? So now regarding your esophageal cancer, so what I want you all to remember is this particular chart. Now the main question that is framed over here is that achalasia is your risk factor for your squamous cell carcinoma, whereas your Barrett's esophagus is your risk factor for your adenocarcinoma. So I would want you all to remember this particular point. Apart from that, esophageal carcinoma, there is the role of your endoscopic ultrasound, the treatment. The treatment in terms of surgery would be a transhiatal esophagectomy, or you have a 2-stage procedure, or a 2-incision procedure, or a 3-incision procedure, right? So those names are very important, like your McKeown procedures for your esophagectomy. So apart from this, in esophagus, what you all should remember is regarding your hiatus hernia. So there are 4 types of hiatus hernia. So type 1 is where your esophagogastric, I'll just write it down for you. So type 1 is where your or you can just actually listen to it. Type 1 is your esophagogastric junction is displaced upwards. Type 2, where only the part of stomach, dilated stomach, goes upwards and the OGG remains normal in position. Type 3. In type 3, what happens is it is a mixture of type 1 and type 2. And in type 4, you have another organ apart from the stomach. Usually, most commonly involved is your colon. Right. So apart from this, the named surgeries in your esophagus, again, you can look at the reels which are in your YouTube channel of GAMEPG app, as well as it is in the YouTube channel, my YouTube channel, where we have discussed this surgeries, McKeown, Oringer surgery, or the Ivor-Lewis esophagectomy, right? So these are your few other important points which you need to remember. Now coming down to the next topic is regarding the stomach. Now in stomach, the most frequently and the most important questions that are asked is including from the lymph node stations of the stomach. So I have named all the lymph node stations which I would want you all to remember. Lymph node 1, station 1 is right cardia. Then you have your left cardia, lesser curve. 4SA is your short gastric. 4SB is your left gastroepiploic. 4D is your right gastroepiploic. 5 is your suprapyloric. 6 is your infrapyloric. 7 is around your gastric artery. 8 is around your anterior hepatic artery. 9 is around your celiac artery. Now 10 and 11 is your most common confusion which you need to avoid over here, right? So 10 is your splenic hilum and 11 is your splenic artery. 12 is your left hepatoduodenal. 12 BP is your posterior duodenal, 13 is your retropancreatic, and 14 AV is the superior mesenteric vein, 14A is the superior mesenteric artery, 15 is for your middle colic, 16A is for aortic hiatus, B2 is for para-aortic caudal, and A2B1 is for para-aortic middle. Now definitely this is a huge chart, but what I would all want you all to remember definitely is your splenic hilum and artery, and I would want you all to remember your retropancreatic and your hepatoduodenal, and others are quite easy. Do not make a mistake. 10 is splenic hilum and 11 is splenic artery, right? Now again, a very important table. So this is much more of a physiological question, question from the physiology, but then I would want you all to remember this for sure. Now, gastric cell types, location and function. Cell type, parietal, location is body, and secretion of acid and intrinsic factor. Mucus, body and antrum, and its function is to secrete mucus. Chief cell, the location is body and the function is to secrete pepsin. Surface epithelial cells, it is a diffuse location and the function is to secrete mucus, bicarbonate and prostaglandin. Enterochromaffin like GD, so enterochromaffin like cells are in body and they secrete function histamine. G cells are in the antrum, responsible for secretion of gastrin. D cells in body and antrum, somatostatin. Gastric mucosal interneurons again are located in body and antrum, and they have your gastrin releasing peptide. Enteric neurons is diffuse in location, calcitonin gene relating peptide and others. And then you have your endocrine, which is again located in body and function is ghrelin. So you need to mug up this table and remember, because you have some questions specifically asked like gastrin, right? So they usually ask you with respect to gastrin, it is secreted by your cell type G, and where is it located? It is located in your antrum, right? So this is your very important aspect that is needed with respect to your gastric cell types, location and function. Now, regarding your gastric cancer, I would want to discuss some specific classifications as the questions are usually framed from that. So first I have the Laurin classification. Laurin classification is divided into two, intestinal and diffuse. Now, each and every point has been asked in MCQ or may be asked in future. So intestinal is environment, alright. Environmental, risk factor is environmental, it is familial. Gastric atrophy, intestinal metaplasia are risk factors in case of intestinal gastric cancer, whereas blood type A is in risk factor in case of diffuse type. Men is much more common in women in case of intestinal, women is much more common than men in case of diffuse. Now it increases the incidence with the age in case of intestinal, and whereas diffuse is much more common in your younger age group. Now intestinal is associated with your gland formation, whereas diffuse is poorly differentiated and with signet ring cells. Now, intestinal has a hematogenous spread, whereas diffuse has your transmural and your lymphatic spread. Now, intestinal has your microsatellite instability, whereas decreased E-cadherin is seen in your diffuse type. And P53, P60 inactivation is common to both intestinal and diffuse. So this particular point of decreased E-cadherin is actually a very important point which you should not forget, right? So decreased E-cadherin is seen in your diffuse type of Laurin classification of gastric cancer. Now, what is early gastric cancer? So early gastric cancer is limited to mucosa or some mucosa which may be or without your lymph node involvement. So you can look at this particular scene. This is the Johnson's Japanese classification, type 1, which is protruding, type 2A, which is elevated, type 2B, which is flat, type 2C, which is depressed, type 3, which is ulcerated. Now you have your advanced gastric cancer where it infiltrates muscularis. So this is a Bormann classification, which is your polypoid, ulcerating, infiltrating and linitis plastica. Now I've again not discussed the TNM classification because those are the classification which you need to remember. So I'll again give you a supplement of your TNM classification video which will be available in your GAMEPGAPP YouTube channel. So make sure that you go through that, and I'll also make sure that the PDF is available to you guys so that you can keep revising. So TNM from your head to toe, each and every cancer shall be included in that PDF, right? So it is already in preparation process. So I think it should be available to you before your FMG exams. I'll make sure that it's available to you guys, right? So this is with respect to your gastric cancer. Now, with respect to your gallbladder. Now, gallbladder, you have your acute cholecystitis, chronic cholecystitis, colorectal cyst. Now, colorectal cyst is your important thing you need to remember is your Todani classification, which is for your choledochal cyst, right? So this classification again has been repeated and discussed a lot many times. I've not included this in this particular video. You can find the same in the GAMEPGAPP YouTube app channel. In case you don't find, just let me know, we'll share it over there, right? Now what I wanted to discuss in gallbladder was your biliary injury. So there's this particular classification which is known as your Strasbourg classification. Now class A. Now, these are your injury to the small ducts in continuity with the biliary system with cystic duct leak. Now, type B is your injury to sectoral duct without any consequent obstruction. Now, type C is injury to your sectoral duct with obstruction and consequent bile leak, and option D is your lateral injury to the extrahepatic biliary duct. Now you have this bismuth part of classification which has not been included. Now E1 is your injury which is more than 2 centimeter distal to the bifurcation. E2 is which is less than 2 centimeter to the distal to the bifurcation. Now E3 is your stricture at the bifurcation. Now E4 is involving only the right stricture, involving the right and the left bile duct, and E5 would be your complete occlusion of the bile duct. So this is a particular classification is very important and has the potential to be asked in your upcoming exams. Now what are goals of therapy when you have a patient with a bile duct leak? The first is the control of infection or limiting inflammation, which is achieved by your IV antibiotics or your percutaneous drainage. Then you have your clear or the thorough delineation of the anatomy. Now this is achieved with the help of MRCP or ERCP, and you have to re-establish the biliary enteric continuity, which is via tension-free mucosa to mucosa repair and doing by hepaticojejunostomy and trans-anastomotic stents. So these are your goals of therapy. And if you look at this flow chart, this is going to simplify your concept of bile leak. So if bile leak happens, you see the status of the patient. If the patient is stable, check the drain output. If it is low output, that is less than 200 ml, you go for conservative treatment. If it is high output, that is more than 500 ml, then you would go for an ERCP or supportive care. Now, if it is between 200 to 500 ml, you actually go for a supportive care and plus minus 10 days. Now, then you review this patient after 6 weeks and to check for leak. If it persists, then you go for a Roux-en-Y hepaticojejunostomy. Else, it would automatically seal up. Now, in case of an unstable patient, what you do is you check whether there is drain in situ or not. If it is there, you check whether it is functional or not. Now, if it is not functional and if drain is not there, you would go for a USG guided percutaneous drainage. Now, if it is a functional drain, then you go for a conservative treatment and the management of the cholangitis. Right. So this would be your general overview treatment of the bile leak. Now, in your gallbladder section, you need to again remember a few important points, a classification like Tokyo classification. So can anybody say what is the Tokyo classification used for? So yes, Tokyo classification is for your acute cholecystitis. Right, so Tokyo guidelines, or you can say Tokyo guidelines, is for acute cholecystitis. Now, from your gallbladder, so these are your major questions that are actually asked. Now, apart from that, the questions that are also asked is with respect to your CBD. Now, for CBD, you need to remember, right, that MRCP is your investigation diagnostic modality, right? Now, you do usually ERCP where you want diagnosis. At the same time, it is planned for a therapeutic treatment. Else, usually MRCP is now for diagnosis. Now again in your CBD you have your primary CBD stones. Right. So what are your primary CBD stones? Primary CBD stones are those which are formed de novo, that is inside the CBD. Now you have your secondary CBD stones. What are secondary CBD stones? Now secondary CBD stones which come from gall bladder. Now you have your another concept of your residual and your recurrent. So in residual it is more than 2, less than 2 years. Right. So these are your some of the other additional concepts of your common bile of the CBD stones that are usually asked. Now, in case of pancreas, we discussed the pancreatic neuroendocrine tumors. Now, what I would want you all to remember is regarding the serocystic neoplasm. So, I have made this chart, which I think should simplify. Now, if you take a cystic fluid, now you have a low viscosity and a low Ca. Then what you do is check the amylase level. If it is high, it is a pseudocyst. If it is low, it is a serocyst. Now, if there is a high viscosity and high Ca, check the amylase. If it is low, it is mucinous. If it is high, it is intraductal papillary mucinous neoplasm. So basically the entire questions are usually revolving around the serocystic neoplasm of the pancreas. Now you have this another beautiful flow chart or the table which is taken from a Bayesian law. So you have a cystic neoplasm. You investigate with the MRCP or with EUS FNA. Now it is you send the fluid for CA cytology. CA more than 192 indicates mucinous neoplasm. Now IPM or intraductal papillary mucinous neoplasm or mucinous neoplasm. So absolute indication for surgery include your carcinoma, high-grade dysplasia, solid mass, jaundice, enhancing mural nodule more than 5 mm, and main pancreatic duct dilated more than 10 mm. Now you guys should remember this particular values because they will actually twist the value. Like enhancing mural nodules more than 3 mm. No, that's not an indication for surgery. Enhancing mural nodules more than 5 mm is an indication for surgery. Main pancreatic duct dilated, which is more than 10 mm. Now, relative indications for surgery include your growth rate more than 5 mm, serum C90 more than 37, main pancreatic duct dilated 5 to 9.9 mm, cystic diameter more than 40 mm, new onset diabetes mellitus, acute pancreatitis, and enhancing mural nodules less than 5 mm. Right. So, if it is an absolute indication for surgery, you would go for surgery. If it is a relative indication for surgery, you would see if it is an acceptable surgical risk with 1 or 2 indications, or high surgical risk but more than 2 indications, surgery. High surgical risk with 1 indication, you will monitor 6 monthly with clinical evaluation, serum C19 and MRCP EVS. Now, if it is not an indication for surgery, you will monitor the patient with clinical evaluation, serum C99 and MRCP and EVS. Now, a solid pseudo-papillary neoplasm, you would consider a surgery. Cystic neuroendocrine neotumor, you will again consider a surgery. And a serous cyst neoplasm other than benign cyst, you can manage it conservatively. So, for pancreas, you need to have your focus mainly on your serous neoplasm and the pancreatic neuroendocrine tumors. Now, there's another recent entity which is being very famously asked in your MCQ, which is regarding your borderline resectable tumors of pancreas. So, what you need to remember is that in case of borderline resectable tumors of pancreas, you can actually go for a neoadjuvant chemotherapy followed by surgery, or you can go for venous resection where you have the facilities for the venous reconstruction. Some centers are also suggesting for your arterial reconstruction also. So please keep that in mind regarding your borderline resectable tumors of the pancreas. Now, in case of liver, what I would want you to remember is the tumors of the liver, specifically the benign tumors of the liver, right? Because they are your favorite examiner topic. So if you talk about hemangioma, it is the most common solid tumor, most common benign. It is male is equal to female. OCP you not associated, soft bluish red spongy mass. Usually asymptomatic. Giant hemangioma is usually when it is said to be more than 4 cm. Now, diagnosis first line is USG. MRI is much more useful compared to CT scan in case of hemangioma. Indication of surgery is rupture, giant hemangioma, unsymptomatic. Now, slow contrast enhancement due to small vessel uptake in hemangioma is seen in your investigations. Now, in case of your focal nodular hyperplasia. Now, male is equal to female in case of hemangioma. In case of focal nodal hyperplasia, female has a better preponderant continuous. It contains hepatocytes and Kupffer cells. It has a central stellate scar, encapsulated, lobulated, and septate mass. Now, the hallmark is your presence of your bile duct elements and the absence of your portal venous structures. Now, look at over here, the hallmark is your presence of bile duct elements and absence of portal venous structures and central stellate scar. Now, diagnosis is with the CT, MRI and your sulfur colloid scan, and there is no malignant potential and you will not require any treatment. So please remember, the focal nodular hyperplasia, you require no treatment. Now, regarding the hepatic adenoma. So female is again more common than compared to male. It is strongly associated with your hepatic adenoma, is your strongly associated with your oral contraceptive pills. Now, this is one of the most commonly mistakes where students mark focal nodular hyperplasia. No. It is OCP which is associated with your strongly associated with your hepatic adenoma. Now, it is associated with your type 1 glycogen storage disorders, diabetes mellitus. The hepatocytes are present and Kupffer cells are absent. Now, in case of your focal and nodular hyperplasia, you had Kupffer cells also. So, now the portal venous structures are present and the bile duct elements are absent. Diagnosis is again by your MRI or CCD scan, and it has increased levels of alpha fetoprotein. So hypervascular and heterogeneous on arterial phase and isodense and hypodense on portal phase as a result of AV shunting. Acute hemorrhage, you would go for an hepatic artery embolization, resection for symptomatic mass, and resection before a planned pregnancy. So that is your treatment plan for your hepatic adenoma. Now, apart from that, in your liver, I would want you all definitely to remember your CTP classification. You cannot make mistakes in such questions because this have been like repeated. And in order to avoid mistakes in this, all you need to do is keep revising. Right. So child Turcot works classification: bilirubin less than 34 to 50, more than 50. Albumin more than 35 to 35, and 3 is given for less than 25. Please remember the values over here, right? Gram, micropole or micromole per liter. Then you have ascites, which is none, easily controlled and poorly controlled. Encephalopathy, which is none, grade 1 or grade 2, grade 3 or 4. And INR, you have less than 1.7, 1.7 to 2.2, and more than 2.2. So this is your child Turcot classification of your hepatocellular function in your cirrhosis. So the CTP score is actually very important for any exam. You need to remember, they can actually ask you from this particular points itself only, right? What are the components? Bilirubin, albumin, ascites, encephalopathy, INR. And remember, CTP A is 5 or 6 points, B is 7 to 9 points, C is 10 to 15 points. So this is all about your important aspects of liver. Now, apart from that, we will also discuss this amoebic liver abscess. So this is majority in the right lobe. How does it present? It would present to you as abdominal pain, anorexia, fever, night sweats, and malaise. So the questions in your exam can actually be with the help of your CT scan or an ultrasound, where you find the well encapsulated mass like this. The causative agent is usually your entamoeba histolytica. Right. Imaging methods are USG, CT, and your drugs treatment would be metronidazole, tinidazole, or your diloxide furanate, which is 10 days to destroy your intestinal amoeba. So, and if it ruptures, you would be requiring your peritonitis. Now, apart from that, another cystic lesion of liver that is very important is your hydatid cyst. So anybody and everybody should be actually knowing regarding this organism causing it. If you do not know it, make sure that you do not skip on it, right? So it is Echinococcus granulosus, right? So now this is the particular classification of hepatic hydatid cyst, which you should remember. So CL is your cystic lesion, which is the unilocular aneuploidy lesion without internal echos or septation. CE1 is your uniformly aneuploidy with fine internal echos that represent proctosolysis after rupture of a vesicle called hydatid sand. Now CE2 is your cystic with internal indentation representing the walls of the daughter cyst described as multivesicular, honeycomb, cartwheel, and rosette formation. So honey, honeycomb, cartwheel, and rosette formation is seen in CE2. Now CE3 is your transitional stage description of your daughter cyst. 3A daughter cyst with detached laminal membrane. 3B is your daughter cyst inside a solid matrix. Now CE4 is your inactive daughter cyst, can no longer be seen, mixture of hypoechoic and hyperechoic features like a bag of wool. So these are your some one-liners which can directly be put forward. Bag of wool is which stage? CE4. Now CE5 is a calcification of the wall, either partial or complete. So over here, if you look over here, hydrated sand is in CE1. In CE2, you need to remember honeycomb, cartwheel, and the rosette formation. In CE3, you need to remember your daughter cyst. Right. Now CE4, bag of wool, and CE5, calcification. I think if you remember these keywords, it should help you to exclude most of the options and mark your correct answer. Now again, these are your images which you can see over here regarding your hydrated cyst. Right. Now the next would be your bariatric surgery. So the indications and the contraindications have been explained multiple times. In case you have having a difficulty, again I would ask you to just drop in a message. We shall share the video, and you can actually find these videos even on our GAMEPGAPP YouTube channel. Now what I want to focus over here is the types of bariatric surgery. Now, there are three types of bariatric surgery: malabsorptive, restrictive, hybrid. Now, malabsorptive includes a biliopancreatic division with or without uterus switch. Restrictive includes a vertical band gastroplasty, sleeve gastrectomy, and laparoscopic adjustable gastric banding. And hybrid is your Roux-en-Y and omega loop. So if you look over here, I've just taken this images. So this is an image showing your sleeve gastrectomy, where your concerns are your staple line leakage and your symptomatic reflux. Right, and de novo Barrett's esophagus. Now if you look over here, this is a gastric bypass showing a short vertical less curvature, right? So over here, biliary limb is kept short, so reduce vitamin and mineral deficiencies, and length of Roux limb is around 100 to 150 centimeter. So now over here you have a gastric bypass with a longer vertical curvature. So the main concern over here would be your biliary reflex induced gastritis. Now you have this adjustable gastric band. So you have your pars flaccida, which is your most common technique, right? Now through the window of the lesser omentum, band placed below the esophagogastric junction. Now this is again your important part, where you have your biliopancreatic diversion with the uterus switch variant and the single anastomosis due to ideal bypass with sleeve gastrectomy. So you look over here, the elementary limb is 100 to 250 centimeter. The common channel is 75 to 125 centimeter, whereas in case of the single anastomosis due to annual bypass, common channel is around 250 to 300 centimeter. So main differences is higher nutritional complication in case of a biliopancreatic diversion, greater weight loss than other procedures, sleeve, and what is done? Sleeve gastrectomy, division of the duodenum distally to the pylorus, followed by your ileum division and duodeno-ileostomy and ileo-ileostomy. Now over here, sleeve gastrectomy and end-to side duodeno-ileal anastomosis. So what is the advantage over here? You have your preservation of the pylorus, elimination of one more anastomosis, and you have your reduced operating time. So the common channel questions can be asked, and also regarding what is done in your single anastomosis, duodenal bypass with sleeve gastrectomy. Now regarding your estimated surgical complication with bariatric surgery, so sleeve gastrectomy, you have early leak at the angle of his intra-abdominal bleed, DVT, or delayed complication include GORD, Barrett's, and weight gain. Now gastric bypass, you have anastomotic leak, intra-abdominal bleed, DVT, and unspecified obstruction, and you have internal hernia as late complications and chronic abdominal pain, malnutrition, anastomotic strictures, and weight gain. Now gastric band, you have access port side infection, DVT, and pulmonary embolism, and the late complications would include band infection, tubing, slippage, erosion, band into stomach, band intolerance, and failure to lose weight or weight regain. So this were your important points with respect to your bariatric surgery. Now in indications, I would want you all to remember BMI more than 40 is a sure indication, and BMI more than 35 is indication along with the presence of comorbidities. So these are two important questions that are actually asked, right? Now, regarding your inflammatory bowel disease, so this important table, if you just revise before your exam, should help you to solve at least around 70 to 80% questions on inflammatory bowel disease, because they are actually mainly related to Crohn's colitis and your ulcerative colitis. So diarrhea. So diarrhea is common in Crohn's as well as ulcerative. Rectal bleeding is almost present in ulcerative colitis. Abdominal cramp is moderate to severe in Crohn and mild to moderate in your ulcerative. Palpable mass at times is seen in Crohn's, but it is not seen in ulcerative colitis. Now, anal complaints are frequent in case of Crohn colitis, whereas it is infrequent in your ulcerative colitis. Now, your radiologic findings. What you need to remember, the toxic dilation is rare in case of Crohn's and it is uncommon in case of ulcerative colitis. Ulcers are usually linear or cobblestone fissures in case of Crohn's, whereas it is your collar button in case of ulcerative colitis. Now, there are skip lesions which are seen in Crohn colitis, whereas in rectum extending proximally and continuously. Now, ileal disease is again common in case of Crohn's, whereas it is rare in case of ulcerative colitis. Nodularity and fuzziness is present in case of ulcerative colitis, whereas it is absent in case of Crohn colitis. Now you have your proctoscopic findings, where you need to remember that anal fissure, fistula abscess is common in case of Crohn, whereas it is rare in ulcerative. Rectal sparing is common in case of Crohn colitis, whereas it is again rare in case of ulcerative. Now, ulceration is linear, deep, scattered, whereas it is superficial and universal in case of ulcerative colitis. So, apart from this, you need to remember the Monter classification for the Crohn disease, which includes your age at diagnosis. A1 is less than 16, A2 is 17 to 40, A3 is more than 40. Behavior is B1 non-stricturing, non-penetrating, B2 is stricturing, B3 is penetrating, and P is perianal disease modifier, where you can add to B1 to 3. Location, L1 is ileal, L2 is colonic, L3 is ileocolonic, L4 is your isolated upper GI tract. So this is again a very important concept from the Crohn disease. Not concept, rather it is actually a direct straightforward question where you need to remember the name of the classification and the parameters. They can actually put a clinical based scenario like a 18-year-old boy presenting with a stricturing lesion in the colonic region. What would be your Monter classification as per the Monter classification for the Crohn disease? Now in your IBD you have one more important point, which is your extraintestinal manifestation. Now it is related to disease activity, include your erythema nodosum, then you have your pyoderma gangrenosum, then you have your arthritis, and then you have your eye complication, iritis and uveitis, aphthous ulcer, amyloidosis. You need to remember that arthritis is your most common extraintestinal manifestation, right? And unrelated to disease activity include your gallstones, rectal renal calculuses, primary sclerosing cholangitis, chronic active hepatitis, and your sacroiliitis. So the questions can be framed as which of the following is not related to disease activity, which of the following is related to disease activity, and which of these is the most common extraintestinal manifestation. Now moving down to the colon. So this is your Haggett classification for the polyp. Now you need to remember this particular classification for your pedunculated polyps, where you have level 0, which is your non-invasive, right? So level 0 is your non-invasive. Then you have your level 1, which is invasion into the head of the pedunculated polyp, right? Then you have your level 2, which is into the neck of the polyp. And then you have your level 3, which is invasion into the stalk of the polyp. And then you have your level 4, which is invasion into the base of the pedunculated polyp. Now in case of sessile polyp, right? So now this all polyp are level 4 in case of sessile polyp. Now apart from polyps, what I want you all to remember is the polyposis syndrome. Now specifically the familial adenomatosis polyposis. Now it is presence of more than 100 colorectal adenomas. Now, extracolonic manifestation. Now, you need to remember which are endodermal derivatives, which are ectodermal derivatives, and which are mesodermal derivatives. Now, endodermal derivatives include your hepatoblastoma, gastric fundal polyps, and adenomas and the carcinomas, particularly around the duodenal ampulla, but also stomach, small intestine, thyroid, and biliary tree. Now, ectodermal derivatives includes epidermolysis, pilomatrixoma, congenital hypertrophy of retinal pigment epithelium, and brain tumors. Whereas the mesodermal derivatives are desmoid tumors, osteomas, and dental problems. Now, they have your 80% of your positive family history, usually associated with mutation in the APC gene on the chromosome 5. Lifetime increases risk of colorectal is 100%. So it is 100% in APC gene mutation, and prophylactic surgery to prevent colorectal carcinoma includes your colectomy with ileorectal anastomosis, total proctocolectomy and ileostomy, and restorative proctocolectomy with an ileal anal pouch anastomosis. Right. Other polyposis syndrome, I would definitely want you to remember this polyposis syndrome because this are being frequently asked these days. It is again HNPCC, autosomal dominant, risk of colorectal, endometrium, ovary, stomach, and small intestine. Mutation includes in MLH1, SH2, MSH6, and PMX62. Now, what I want you to remember is your Amsterdam criteria. 3 or more family members with the Lynch syndrome related cancer, 2 or more successful affected generation, at least 1 tumor diagnosed before age of 50 years, FAP excluded, and tumor verified by your pathological examination. So this particular criteria need to be remembered. FAP excluded, 2 or more successive generations included, at least 1 tumor before the age of 50 years, and FAP excluded. Now, regarding the colorectal carcinoma, most developed from which type of polyp? Adenomatous polyp. Now, this is the adenocarcinoma sequence where I need to you all to remember. The first one is 5q mutation or loss of FFP, which is between your normal and hyperproliferative epithelium. Now, KRAS mutation is between your early adenoma and your intermediate adenoma. Then you have your P53, which is between your late adenoma and carcinoma. Now, this P53 is actually your marker of invasion. Now, between your intermediate adenoma to late adenoma, you have 18q loss also, and DNA hypermethylation has an effect on your early adenoma. So, saying for the evidence of the adenoma carcinoma sequence, you have the distribution of adenoma similar to cancer. Larger adenomas are more likely to be dysplastic. Majority of early cancer adjacent adenomatous tissue adenoma are found in 1/3 of specimen resected for colorectal cancer, and incidence of colorectal cancer decreases within a screening program that involves colonoscopy and polypectomy. So this has been asked as true and false statement questions, right? So please do remember this. This can come even as an all of the above question. Now, regarding the distribution, please remember the maximum distribution is actually seen in the rectum, followed by your sigmoid colon. Now, regarding your presentation, so you have your right-sided colonic carcinoma, which will have a different presentation compared to your left-sided colonic carcinoma. So, right-sided, you will have an abdominal mass, melena, diarrhea, right lower quadrant, abdominal pain, whereas left colonic, you will have your alteration of bowel habit, passage of blood or mucus stool, left-sided abdominal pain and mass, and acute or chronic obstruction. Now, spread would be via your direct lymphatic and hematogenous spread. Now, liver via portal vein is much more common compared to lung. Now, Duke staging is A is invasion but not breaching muscularis propria, B is muscularis propria breach, C is lymph node metastasis. Now, regarding your TNM, so I've included the TNM of rectal cancer over here, but I'll ensure that I'll make a TNM chart for all the cancers and give you very soon. So T1 is invade into the submucosa, T2 is into the submuscularis propria, T3 is non-peritonealized pericolic tissues, T4 is visceral peritoneum, and T4B is invading your another organ or structure. So you have your nodes N1 or 3. N1 is 1 to 3 nodes involved, N2 is your 4 nodes involved, M0 is no metastasis, M1 is metastasis, M1 A is metastasis confined to one organ, M1B is metastasis to more than one organ. What you need to remember is M1C, which is your metastasis to peritoneum, right? Now, regarding the screening, the ideal age is 50 years. Investigation of choice is your colonoscopy, pre-op evaluation, no more mechanical bowel preparation, right? So these are your key elements of your ADAS program. We had discussed this when we began the session in your metabolic response to injury regarding your ADAS technique. So you have your pre-admission counseling, pre-op carbohydrate loading, avoidance of pre-op dehydration, avoidance of nasogastric tube, short-acting anesthetic drugs, avoidance of fluid overload, short transverse incisions, avoidance of opiate analgesia, maintenance of perioperative temperature, prevention of post-operative nausea and vomiting, early mobilization, early introduction of oral fluids, diets and supplements, now early removal of urinary catheters, and continual audit of outcomes. Now regarding your surgery, so you have this uh, diagram over here, so showing your right hemicolectomy for your cancers of cecum and ascending colon. So you have your left hemicolectomy for descending colon and your sigmoid colon. Extended right is done for your carcinoma transverse colon and splenic fracture, and adjuvant CT is for your stage 3 and Duke C, which is your fluoropyrimidine agents and oxaloplatin, right? Now, in case of rectum, the most VVI topic of rectum is your rectal prolapse. So it is of two types: mucosal prolapse or your full thickness prolapse. Mucosa, only mucosa, usually in children after diarrhea, loss of weight and loss of fat, which can be associated with your cystic fibrosis, Hirschsprung disease and rectal polyp. Right, in adult, it is usually associated with your third degree hemorrhoid. The treatment in young children is usually by digital repositioning and submucosal injection, whereas in case of adult, it is a local treatment and excision of your prolapsed mucosa. Now, full thickness rectal prolapse is usually with mucosa and submucosa, usually commences as interception of rectum. So this is your key point to be remembered. Now, where does it start? It starts in the anterior wall of the rectum, and supporting tissue are the weakest, right? So this is an example of your full thickness rectal prolapse where the whole bowel wall has protruded out through the anus, right? Now the treatment are two types of procedure: pelvic and the abdominal. Pelvic is easy, less time, increased recurrence, and old patient, includes Thier's wiring, Delorme and perineal rectosigmoido rectosigmoidectomy. And in case of abdominal, it is difficult, increased time, less recurrence, young and fit patient, resection rectopexy and suture rectopexy. So they have asked you the questions on the procedures for your rectal prolapse, abdominal procedures and the pelvic procedures. And now they have also been asking you questions regarding the images. So you need to remember this is your Delorme procedures. Now I would say at least remember the image. This is your Delorme procedure. This is your Altimier's procedures, and this is your ventral mesh rectopexy, right? So this is with respect to your rectum. The rectal cancer will have a lot of similarities with colorectal colon cancer, as usually it is studied as one entity, colorectal cancer, right? So that important points which have been discussed for colon cancer should suffice your preparation for this. And apart from that, if there is any doubt, please do read, and if you have to ask again, you can drop a message or an email. Now regarding anal canal, so this is a topic from where a lot of short topics and a lot of one-liners do come up. So let's look at the first question, which is usually from the embryology section of the anal canal. That is your dentate line. So you have your embryological junction between the endodermal and the ectodermal part of the anal canal. So above the dentate line is your endodermal, which is columnar, sensitive to stretch, internal iliac veins to internal iliac lymph node, and superior rectal vein to portal. And below the dental line is ectodermal, squamous, somatic innervation, sensitive to pain, inguinal lymph node, and inferior rectal vein to the systemic venous. Now apart from that, coming down to the anorectal malformations, so what I want you all to remember over here is a few flowcharts, right? Because they have tendency to ask regarding the management. So if it is a newborn male, you will go for a perineal inspection. Now 20-24 hours, then you will go for a where you will be evaluating regarding the spine, kidney, urine analysis, rule out esophageal atresia, sacrament, do an echocardiography, then you do a re-evaluation in the cross-table lateral film. Now, if it is a perianal fistula, you go for an anoplasty. If it is a rectal gas below coccyx, you consider a posterior sagittal anorectoplasty. And if it is a rectal gas above coccyx, you do a colostomy. So this is the type of management in case of your newborn male. Now, one more important one-liner you can remember is wing spread, right? So wing spread classification is for anorectal malformation. Now, in case of newborn female, now you rule out the associated defect, you do a perineal inspection. Now if it is a single perineal orifice cloaca, you do a urology evaluation, rule out hydrocolpos and do a colostomy and drain the hydrocolpos. Now if it is a perianal fistula, you will need to do an anoplasty or an anodilation. If it is a vestibular fistula, you would require a primary repair or a colostomy. Now if there is no visible fistula, then after 24 hours, do a cross-table lateral x-ray. If it is in low rectum, do a primary repair. If it is in high rectum, you do a colostomy. So if there is a question on anorectal malformation, I think the modern day questions would generally be centralized around these two charts or the flow chart which I have explained to you right now. Right. Now, this is again a procedure which is done for pilonidal sinus. So I would want you all to remember the procedure name, the Bascom procedure. Now, this can come as basically an image-based question, right, where you give a lateral incision and curettage only. Now, this is what we had studied in the plastic also, right, a pilonidal sinus flap. So this right, so this is your Cariadakis flap and your Limburg's flap. So this first one is your Cariadakis operation, and then this is your Limburg procedure, right? You can see the rotational advancement flap over here. So these three procedures are used for your pilonidal sinus. So they can be image-based question asking you what is the procedure called, or they can ask you which of the following procedures are used for pilonidal sinus: Bascom procedure, Cariadakis, and Limburg. Now regarding your anal fissure, now this is one of the most common topics, or not topics, sorry, one of the most common cases that we come across our OPD. So if you see the location of fissure is lateral, you can consider it to be Crohn's, TB, syphilis, cancer, HIV, or AIDS, and have to do investigations accordingly. Now if it is a midline, then you go for a non-operative management like topical nitrates and calcium channel blockers. Now for operative, you need to remember you do a lateral anal sphincterectomy. Now if there is failure to heal, then you consider examination anesthesia, consider biopsy, or the evaluation of sphincter. If it is hypotonic, you would go for a fissurectomy with advancement flap. Now if it is hypertonic, you will go for a repeat sphincterectomy. So this is with respect to your anal fissure. Now again, they have asked questions, lateral anal sphincterectomy, you need to remember. Now this is with respect to your anal fistula, right? Fistula. So last year they had asked you regarding the gold standard of investigation. The gold standard of investigation. So this is your MRI. Now most common is your intersphincteric fistula, right? And then followed by you have your transsphincteric, and then you have your suprasphincteric and your extrasphincteric. Now what is this classification called? Parkes classification. So these are very few important one-liners where you should not be missing, right? Now, so I think this is all about your anal canal. Now, a few important topics for the urology section. This would be our last section for today, right? So first we have your renal cyst. Now there's a classification which is named as Bosnoid classification. This is as per the malignant potential of your cystic lesion. So if you look over here, class 1, there are no septa, no calcification, no solid component, and no enhancement. So this has around 0% chances of being malignant. Now type 2, there's a few hairline thin less than 1 mm septa, which is thin calcifications and well marginated. So again they have like 0% chances of being malignant. Now 2F, they are well marginated, no enhancement, high attenuated lesion, more than 3 cm, totally intrarenal. Now this are 6 months, 12 months, and 5 years follow-up is required for this case. Now in case of 3, where 50% are malignant. So this is a thick, irregular or smooth wall or septa. They have measurable enhancement. So partial nephrectomy or RFA in poor surgical candidates is needed. Now, in case of category 4, it is 3 plus enhancing soft tissue components adjacent to but independent of wall or the septum. So you will again require a surgical treatment. So please remember category 2F will are 5% chances of malignant and you would require it to be followed, whereas category 3 are around 50% of malignant and you would require a treatment of partial nephrectomy. Now, apart from this, in kidney, you would need to remember the TB changes or the changes that occur in tuberculosis. So we have this urology section video for covering the NEET previous year questions in your GAMEPGAPP YouTube app channel, so which I would want you all to visit and make sure that you look over there. Right now, apart from this, in kidney section regarding the kidney cancer, again it has been discussed multiple times. I'm not included in this particular session of today's. Now if you want to know that, please let know. We'll again have an add-on video for that very soon, and irrespective we shall be discussing the kidney cancer when we'll be discussing TNM stages of all the cancers, which I'll be sharing the PDF very soon. Now regarding the torsion of testes, so this is the twisting of the spermatic cord and its content, as a result of which what happens is that testicular blood supply is compromised. If untreated, blood flow ceases, and as a result of which testicle die. Now it is a surgical emergency. Now there are two types, extravaginal and intravaginal. Extravaginal is usually limited to neonates and increased mobility before the descent into the scrotum. Now intravaginal, it is beyond the neonate age, and this is the high investment of the tunica causes the testes to hang within the tunica like a clapper in the bell. So if you look over here, this is the normal attachment. This is an abnormal attachment over here of the tunica vaginalis, which predisposed to the torsion, and this is your separation of the testes from the epididymis. Right. So various risk factors includes your separation of epididymis and the inversion of testes. Now factors determining the damage is your extent of twist. So a 720-degree twist is definitely going to cause much more damage compared to a 360-degree twist, and the duration of damage, if it is done within 6 hours, you can actually salvage almost 100% of the testes, but if it is, and which drastically drops down to 20 hours if it is beyond the 24 hours period. Right. So clinical features include your sudden severe pain in groin and lower abdomen, nausea, scrotum is swollen and tender, and cremastic reflex is lost. Now differential diagnosis includes the epididymoorchitis, where the elevation of the testes usually reduces pain. Now this is known as your friend sign. Right. And the idiopathic scrotal edema, where usually you do not find any tenderness. So another important entities are your torsion of appendix testes and torsion of appendix epididymis. So this is your remnant, appendix testis is your remnant of your Mullerian duct and also known as hydatid of Morgagni, and you have your blue dot sign seen, and it is most common between the age 7 to 14 years, and it can be treated conservatively. Now torsion of appendix epididymis is your remnant of Wolffian duct. Now please remember this blue dot sign. This can itself be asked as a direct one-liner, or it can be an image-based question where you will be seeing a blue dot sign, where you will be seeing a blue dot in the testis, which is seen in your torsion of appendix testes. Now this is an ultrasonography, right, which is showing the one testes absent blood flow. So in a colored Doppler, you would actually see in your testicular torsion absence of blood flow. Now when you do an exploration, if it is viable, you do a non-absorbable suture fixation and other testes are also fixed. If you have a clinical doubt, you wrap in warm swab, incision in the tunica albuginea, and see if there is any bright red bleeding. And if it is infected, you need to remove, and always make sure that the opposite side also you will do an orchidopexy. Now, the examiner's favorite again for your Fmge, Fournier's gangrene. So this is your progressive infection of the genitalia, perineum and perianal region. It is a mixed bacterial, that is a polymicrobial infection associated with your diabetes, cancer, malnutrition, and urological and colorectal inflammation. So hallmark is your rapid progression from symptoms and signs of cellulitis. Now, there is intense pain and tenderness in your genitalia region. The clinical features include your erythema, swelling, pain, blister, and foul smelling necrotic lesions. And along with that, you have your subcutaneous crepitation. Now, the progress from the genitalia to perineum to abdomen occurs very rapidly. Now, it is a surgical emergency where you would need to deal with surgical debridement, IV antibiotics, and urinary fecal diversion may be necessary. It is not required in all the cases. Now, testis is usually spared in your Fournier's gangrene because of the concept of the dual blood supply of the testes, right? Now, regarding your undescended testes, now they usually complete the descent by your 30th week of gestation. Now, how will you differ between the undescended and ectopic? So if it is within the line of descent, that is your undescended testes. If it is deviating from your line of descent, that is your ectopic. So you can see the most common sites are your superficial ectopic, femoral, and your transverse scrotal. Now 3% in your full term and 30% premature infants, one of both side undescended, reach scrotum by first 3 months. Now, orchidopexy should be done within 6 to 12 months. Right side is much more common compared to left and bilaterally seen in around 20%. Now, what are the consequences of undescended testes? It may be lead to infertility, malignancy. What is the most common malignancy? Seminoma. Now, hernia 90% and testicular torsion. Now, retractile testes, you have it because of cremasteric reflex. Now, what happens in case of retractile testes? Your scrotum is well developed. So that is how you're going to differentiate it from your undescended testes. Now, this is your most important point to be discussed in your undescended testes. So if it is unilateral palpable, non-palpable, you do a laparoscopy. If it has a blind ending vessels, it is a monarchia and you excise the part of it. Now, if it is doing a laparoscopy and you find that the vessels are exiting the internal ring, then you go for an inguinal exploration followed by an orchopexy. Now, if it is an intra-abdominal testis, then you go for an orchiectomy. That is when you find it to be a unilateral non-palpable. Now, in case of bilateral non-palpable, you first do an HCG. There is no response, that means it is an anorchia. Now, if there is an increased testosterone, and increase FSH and LH, then you go for a laparoscopic or plus minus exploration. Now, in case of intra-abdominal testes, you again need to also do a Fowler-Stephens orchiopexy, which can be a laparoscopic approach or an open approach. So normally, what we can expect is that we just need to follow this chart. Unilateral non-palpable, bilateral non-palpable. Unilateral non-palpable, next step laparoscopy. Bilateral non-palpable, next step HCG. That is what we can get a question from here, and then they might definitely step it up ahead. Now, a few important short note diseases from your urology before we wrap up the session today. So, hypospadia. So, this is one of the most common congenital malformation of the urethra. Now, it is 1 in 300 male live births, condition where urethral meatus opens on the underside of the penis or perineum, ventral side proximal to the tip of glans penis. Now, what are the characteristic features? External meatus on the undersurface of penis, ventral aspect of prepuce is poorly developed, that is a hooded prepuce. Now, ventral deformity of the erect penis, that is caudy. Most common type is your glandular type. So if you look over here, this is your glandular type, this is your coronal type, this is your penoscrotal type, and this is your perineal type, which is your most severe. Right. Now, they may be associated with your undescended testes and inguinal hernia. They have difficulty in urinary stream, painful erection, and infertility. Now, the important points that you need to remember is your principles of operation. So, you have orthoplasty, which is the correction of caudy. Urethroplasty, that is construction of new urethra. Mutoplasty, that is meatal stenosis dilation. And glanduloplasty, which is construction of glans penis. Now, epispadias, you have your dorsal. So, do not confuse it with hypospadias. So, epispadias is the dorsal penile defect, which is usually part of your extrophy and epispadias complex. And the most severe variety is your ileocecal extrophy. Right. Now, coming down to the posterior urethral valve. So, this is a congenital symmetrical valve in the posterior urethra below the varum montanum. Right. So if you look over here, this is a lateral view of a dilated posterior urethra. So you can see this is, I'll just mark it with yellow, right? So this is your dilated posterior urethra. Now this is what your posterior urethral valve, and you can see this as the trabeculated bladder, right? Now, what are the features? The features include your obstructive flow of urine, cricket wall bladder, which are associated with VUR. Now, VUR has been explained probably in your pediatric section, so hence I'm not touching it up out here, but it is a very, very, very important topic. Right, and the treatment is by your fulguration of posterior urethral valves and your endoscopic destruction. Now, apart from this, so with this, I have actually ended. I end my discussion which I had planned, but I'll just give you one more extra point which I just remembered for your PUJ obstruction. There is a procedure which is called as Anderson high pyeloplasty. Right. So this was all about your FMG masterclass of surgery for your July 2023. I hope you found it useful and will be finding it useful for your upcoming exam, and I hope all the surgery questions can be solved from this class. But definitely one class is not sufficient enough, and that too are just a 4 to 5 hour class. But do trust yourself, keep revising, because that is going to be the key to success. Right, now if you have any doubts, you can actually mail it down to me at this email ID. Right, I'll be happy to solve your doubts. And apart from that, you guys can actually follow me on my personal ID on Instagram and YouTube. So I have it shared it over here on YouTube at AK Surgery, and Insta is your.surgery buddy. Right, and also along with this, there are many videos which I uploaded only on the GAMEPG app. So do follow at GAMEPG app. And for your exams, I would just say as the final message, keep calm, and the key to success is only going to be one, which is revision, revision, and revision. So don't panic, keep revising for your exams. Don't think for the what is going to happen with next exams, next pattern and all. You have this July FMG happening, so just focus, stay calm, stay relaxed, and keep revising well. And we at Game are always there to help you. So all the best. Take care.